Hi, this is Wallis-Collier. Just from my first clinical, one interesting case that I was actually able to work with that I'm going to kind of talk about today is a bilateral calcaneus fracture. So it was a really good time. Got to see and experience a lot of different things, as well as just doing a lot of patient education, especially in the early stages. So perfect. That's where we'll roll through it. So the things I'm going to kind of talk about today in this presentation, the anatomy of the patient's injury, so all the things that kind of affected when the calcaneus is fractured. Um, Also, just the mechanism of injury and how the patient was injured, as well as their story. Because it's always important to kind of talk about the patient's story. What the supervising PT's goals were for the patient after discussing with them on the initial eval, kind of where they needed to be heading throughout and after treatment sessions. With all that being said, all the different protocols and treatment considerations that had to be taken into effect, as well as patient education that we did. And then I was also just going to talk about a typical treatment session and then a little reflection there at the end. So perfect. Let's roll into it. So all the anatomy, of course, in a calcaneus fracture, what do you need to know? Calcaneus. It's the largest tarsal bone. It's the majority of the person's body weight. So that, as we'll kind of see, plays in a lot of different things when it comes to protocols. And then also with the calcaneus being fractured, the two joints within the ankle that are affected, the subtalar joint, which is inversion eversion of the ankle, and then the talocrural joint, which is the true ankle joint, which is promote mostly plantar flexion and dorsiflexion. And then, of course, the Achilles tendon attaches at the base of calcaneus, which is important for plantar flexion and walking. And then also a big thing with this case was loss of uh, arch support. So plantar fascia, which originates on the calcaneus, is very important for arch support, as well as many other foot intrinsic muscles that attach to the calcaneus that play a key role, again, with just supporting that arch. So perfect. Let's move on. So, how did this patient get injured? The patient was on top of their boat in their driveway and jumped off the boat and landed on their concrete with their legs straight. The force transmitted through their calcaneus, which is very common, according to McCormick.com. It's the most common way that people will actually injure or fracture their calcaneus, as it's from falling from large heights, jumping off ladders, jumping off balconies, and also just motor vehicle accidents. It takes a lot of extreme force to break your calcaneus. And then also when it comes to it, just kind of the associated symptoms, just kind of very basic at the very beginning, severe pain to the back of the ankle, pretty instant swelling, as well as the inability to bear weight or walk during it occurs. So how this patient presented. They were a post-op ORIF on bilateral ankles. So that being said, their scarring kind of looks similar to this bottom photo here on both sides, and then hardware looks similar, just kind of this first photo. I didn't get a hold of or take photos of either of the patient's actual scans, but this is basically what we were looking at when the patient first walked in. Patient came in bilateral cam boots as they were non-weight bearing for the first 6 weeks. And then actually on the day of their initial eval, they were weight bearing as taller to their right lower extremity while still in their cam boot, unable to take cam boot off when standing, especially for that initial eval. When we were actually able to take that off, extreme stiffness to the ankle and subtalar joint, as to be expected, after being immobilized for nearly 6 weeks. Of course, this also comes with muscle weakness to dorsiflexion and plantar flexion due to that immobilization, as well as increased swelling to the midfoot and Achilles tendon. It was pretty flared up the day of that initial eval that I actually got to sit in and then also work with the patient afterwards. So I was in it from the very beginning until the very end of my clinical rotation. And like that kind of discussed, limited range of motion in all directions. And this is a very, very common clinical presentation for a fractured calcaneus. Orthobullets.com. Calcaneus fractures also basically laid all this out. And this is exactly what we were seeing on that initial evaluation and in the days following when they came in for their visits. So, with that being said, the treatment considerations that we were working with, they were not non-weight bearing for 6 weeks with gradual weight bearing installed to right lower extremity, still no weight bearing to the left lower extremity trying to protect it. they had to be in cam boots until cleared by MD. They were actually cleared from their right cam boot with ambulation after week 8, which was this last week. So we can kind of work on actually doing some real gait training without being in a cam boot. So trying to get that ankle to move a little bit, uh, doing a light heel strike, while also kind of rounding over and getting up onto the toes when they're at their end of their stance. So, and then with that being said, also no early aggressive subtalar joint mobilizations as we're trying to protect that hardware and promote the most healing within the ankle. Also, we'll kind of discuss here too, just doing proper assistive devices to improve gait. On the initial eval, we tried crutches, but the patient felt like they didn't have enough support, especially any like feedback coming from their feet as you're being in cam boots. So they actually would start off in a wheelchair like here, but then they also moved to a walker with armrests as they felt they could put more weight on it and limit the weight they were putting through their right foot when standing. So it was kind of getting it all to kind of work best for the patient. Doing only gentle range of motion and dorsiflexion and plantar flexion. And also that all that being done just to try and protect the incision and the hardware and promote healing within the ankle. These are also very common considerations that I also found from the doctor's protocol, but also through orthoinfo.com for calcaneus fractures. Perfect. So let's kind of talk about the patient's treatment goals after discussing with the supervising PT, and this is kind of what they came up with. So for the 6-week goal, patient will demonstrate full weight bearing in cam boots with no assistive device and wean into shoes when instructed by MD. So kind of already kind of working on that by the end of their second week. Their right lower extremity was out of the cam boot, and they were actually able to put on shoes. Now they were very tight fits with all the swelling, but just getting back to a little bit of normal. At 8 weeks, patient will demonstrate within normal limits bilateral ankle and subtalar active range of motion, allowing him to ascend and descend stairs and walking with a normal gait when in shoes, as the patient still does not have a normal gait pattern, very intelligent gait, just from pain and stiffness. And then at 12 weeks, patient will demonstrate increased bilateral ankle foot strength to within normal limits, allowing him to return to work, golf, and previous level activity. This patient was a huge golfer before this injury, very active guy, loved going out on his boat. That's why he was putting up the boat when he was hopping off. So it was very difficult for him to go back to such a low level of activity. So it was very excited to get back in 12 weeks. So with that being said, kind of patient education throughout this entire process. The biggest thing was non-weight bearing for 6 weeks. And then also for him, it was a lot of swelling in bilateral ankles just because he was just having them down all the time and not really elevating them. So elevate that leg above the heart when able, as well as wearing compression socks. Patient was wearing compression socks and would try to elevate as much as possible, but still having some pretty increased swelling. So we kind of hit that home on the patient education most visits, as well as just icing as often as possible to kind of decrease pain and swelling. While also, since they were immobilized for so long, just trying to watch for any increased redness and swelling, for blood clots, and just kind of letting the patient have that proper education on things they need to be looking out for on their end, as well as just any infections, like if it's getting red and swelling around the incision sites. And if it keeps expanding, might want to call doc to take a look at it. Also talked about how this prolonged stiffness is pretty normal as you had been immobilized for so long. Just things weren't moving. So now it's trying to get everything to get moving and get back to normal range of motion again. Those are kind of our big goals. And then also just talked about how long this process is, as it's not going to be something that's going to come back right away. It's going to be a little bit every single day as long as we're doing these exercises and keep working on it, especially at home, not just in the PT clinic. This is going to give them the best results. Perfect. So what does a kind of a common treatment session look like? The goal of most treatment sessions, unless they came up with super bad swelling, it was just trying to get everything kind of calmed down a little bit, was basically to improve active and passive range of motion on bilateral ankles. So usually we begin the session with some passive range of motion stretching in all directions, as well as usually performing a retrograde massage to try and decrease swelling and get it up and out of the ankle as much as possible. Swelling kind of was a big issue in this case. And then after all that and just kind of getting everything done with passive range of motion in all directions and all the hands-on stuff. Then getting the patient to do active assisted range of motion. We actually found it best with a wobble board in all directions with just decreased pain, just allowing the patient to actually feel a stretch even at the end of the movement as well, doing active assisted range of motion. And then we also would do strengthening exercises in all directions, especially starting out. These weren't anything major bands we were working with here, even in plantar flexion. It was a yellow or red band in TheraBand. So very, very weak after being stuck in those cam boots for so long. And then another big thing here was working in foot intrinsic muscle exercise. So this was things like marble pickups, or even like towel scrunches, or even like trying to do some doming of the foot with some cueing and tapping within the arch of the foot. Though just doing like marble pickups and towel crunches seem to have the best results with getting muscle activation. And then usually we would end, especially with right lower extremity, just standing in balance. Weight bearing is tolerated on right lower extremity after being cleared by MD to take that cam boot off. Even doing a little bit of gait, especially once I got cleared at that 8-week visit, which was earlier this week. So really kind of fun just to kind of get this patient up and moving again after they've been so excited. Yes, and then also I kind of want to go back on the patient education side of things. We also talked about how, this patient was sitting down for a long, long period of time, so just preventing pressure sore. So getting up, moving, getting in different positions, rolling around, lifting yourself up so that you're not just sitting down on your butt all day and getting some pressure sore. So that was also a big part of patient education with this patient. So kind of just my side of things and just my recollection. This was a great case for me, just with proper patient mindset, as this patient was just so active before this injury, and just being such a drastic life change within, a matter of seconds. They were basically out of all their activity levels that they like to do. And before they even came into PT for an eval, they were staying at home for 6 weeks doing nothing. So just a big thing about getting a shift of the patient mindset, just to getting them excited about what we were going to do in PT, setting them up for their goals, and letting them feel very involved and in control of the PT process as much as they could. While also a big thing with this was maintaining MD protocols. This was kind of like my first like real case within the clinic of just getting to see a long MD protocol with just especially like weight bearing uh, applications and gait, and just kind of what the doctor expected for the healing process. So it was a really great and fun experience. Like I kind of talked about with problem solving, and offering patient life adaptations, especially with like the crutches at first patient, like these crutches are not working. So, we got to shift, we got to pivot. So we decided that walker with armrest would be best for this patient for ambulation, especially in the early stages, just especially to get weight off that foot. And just that way they had a little bit more like tactile feedback as they like in their cam boots, like they said, they just felt like they were floating above the ground and they were really just getting no endpoint, as well as that comes from having surgery and um, just decreased sensation in their feet anyways. But I also just thought this case was an amazing opportunity just to learn and get to experience a very hands-on, getting to work with patients like passive range of motion in the ankle. Like the first like 20 minutes of session is just kind of getting this ankle, trying to get moving a little bit, get that stiffness out of the boots before we can even really start doing any like active range of motion or strengthening exercises. So I just loved this whole opportunity in this case, and it was actually just a really fun patient to work with as well. So absolutely loved it, and I hope you guys learned a little bit more about a bilateral calcaneus fracture. So great and fun time to treat. Here are my references. Perfect. Thank you so much.